I was going to record it. Okay, so we're going to focus on next generation and making sure that you guys know some key things. So a key component of this class, of course, is making sure you're familiar with prioritization and delegation, right? So prioritizing care and delegation for a patient is very, very important, especially when it comes to your boards. So prioritizing patient care. So which patient should you see first? These are very, very important because these are the questions that you want to have because they're going to really show, can you critically think? The biggest thing about your nursing care and the care that you deliver, it's okay, out of these 7 patients or out of these 6 patients or out of these 4 patients, based on the information I have, who do I see first, right? So basic thing you want to make sure that you understand, that you really focus on. Whenever you see prioritization questions, you see the word priority, you see the word best, you see the word initial, you see the word first. Prioritization to you means life or death. Okay, and the biggest thing, of course, you guys know is the ABC issues, right? Always take the priority, followed by safety, pain, and comfort issues. So this is really based on Maslow's hierarchy of needs. So with ABCs, it's airway, breathing, and circulation, always in that order. If it's not a physiological problem, if it's not a physical problem, that you notice, it's psychosocial, or a psych problem. Okay, so NCLEX, the biggest thing is they just want to make sure that you're going to be safe to practice. They know as new graduate nurses, when they give your license, you're not going to know every single thing, but will you be safe enough to understand some basic things when it comes to patient care? Okay, and remember Maslow's hierarchy of needs, right? Basic needs are always going to come what first, right? So basic needs include what? Water, food, shelter, oxygen. Those are just basic needs, okay, that we see. So those are always going to be important. In addition to that, of course, ask yourself which patients, stable before, unstable before, stable patients. Now, the biggest thing too, you want to make sure that you can classify patients. What do I worry about as a nurse, right? If a patient has a heart rate of 88, right? Am I going to worry about that? No, right? If they have a heart rate of 62, am I going to worry about that? No, depending on the patient, of course, right? So again, if it's a newborn, if they have a heart rate of 88, do I worry about that? Yes. You see what I'm saying? So that's why you have to focus on who my patient is and of course what the problem is, okay? So, yes, go ahead. Huh? Yes. Yeah, I'm recording so that way you guys can, have it. Especially I'll post it on the class website. Okay, so the other thing is is asking yourself which patients have problems that can wait and which ones need to be tended to immediately. That's going to be very important. The other thing about NCLEX, it's right here, right now. So based on these 4 patients, what's happening right here, right now, who can wait, and then who can I see? Okay, and can any patient be delegated to a UAP? So that's going to be very important. So the biggest thing too with prioritization is knowing, of course, what can you delegate, of course, to your LPN and of course your UAP. In addition to that, you want to think about certain things when you're doing prioritization questions. So is there an acute or a chronic problem, right? What's the difference between the two? Right. And the biggest thing with acute problems, it means that they just what? Just happen, right? So again, you can have a patient that has diabetes, right? And then they go into acute renal failure, right? So my emergency is their what? The renal failure, right? By their BUN creatinine. Am I worried about the diabetes? No, that's a chronic condition. Do you see what I'm saying? So those are things you really want to focus on. And the thing is, what can I fix the most quickly? Right? Is it something I can do with their airway, giving them oxygen, putting them in a high Fowler's position? Those are important things to remember. Also, what could happen to the patient if I fail to act on this right away? A lot of times too, the biggest thing is when you're picking an answer when it comes to prioritization, you want to think, okay, did I do something, right? You really want to focus on, did I do something? Did I choose the one that I actually intervened and did something for the patient? What can I delegate in order to maximize results, right? So again, we're going to talk about the role of the UAP and what they do. What can I delay safely so that I can get something more important done Now, that's very important as a nurse, right? Because the biggest things you want to focus on, am I going to worry about a potential regularly scheduled dressing change that's ordered Q shift? Or am I going to give stat medications for a patient that has a blood pressure of 220 over 160, right? So that's what it means by prioritization. What can I delay, and then what has to be addressed right now? Also, what can I do as a nurse, and what do I need to get in order for? Part of prioritization, and you're going to see next gen when we go through the two case studies, it's kind of called differential diagnosis. So you're going to have to anticipate a lot of things, right? So that's the critical part is, okay, I think the patient might be going into pulmonary edema, right? Why would I think that? Okay, based on the signs and the symptoms, right? And if I ask you, what are the signs and symptoms of pulmonary edema, what would you tell me? Crackles. And a big hallmark sign of pulmonary edema is pink, frothy sputum, right? That's really what you want to see, right? So those are important things, right? And based on that, that's what I think the patient's having. So of course, I'm going to make sure that I know that I'm going to need an order for what? What are some interventions that are ordered for patients that have pulmonary edema? And I'm going to tell you guys the biggest thing that's going to help you is acronyms, right? So there's an acronym for pulmonary edema known as MAD dog. Have you guys seen it? Okay. Yeah, sure that you're very familiar with is delegation, right? It's the process of transferring the performance of a task to somebody else on the healthcare team while retaining accountability, of course, for the outcome. So nurses are responsible for supervising the performance of client care tasks that they delegate to others, right? So they can complete higher level tasks, right? So again, if it's feeding a stable patient, right, is it something that I'm going to worry about, or am I going to delegate it to the UAP, right? Because I have to go hang blood right now, right? So those are important things. Okay, what can I delegate? What can I do? Because the biggest thing is the purpose of delegation is to free you up to do what? Higher level tasks. That's really the purpose, right? So again, can I be making everybody's beds right now or so on and so forth? You see what I'm saying? So that's why it's so important to know, okay, what can I give to somebody else so it can free me so I can focus on drawing up ABGs if I have to, or going to the lab or doing certain things. So that's why it's really important. So again, our higher level tasks focus on medication administration, and of course, starting IVs, inserting, of course, catheters, wound dressings, things of that nature, things that I cannot pass on to somebody else. Okay. And remember, we only delegate stable patients with predictable outcomes. That's it. Stable patients with predictable outcomes, meaning I don't care what you have seen at your job, at your externship, in the nursing home, with abuelita, with gun, with grandma. You see what I'm saying? Those are important. Yes. So the biggest thing too is your supervision, right? So it's the process of directing, monitoring, and evaluating the performance of tasks by another team member. The biggest thing is whatever you delegate, you are what? Responsible for, right? It has to be done, whether the person started it, didn't finish it, so on and so forth, right? So of course you have to make sure the performance of the client task you can delegate to others is going to be completed, right? So you have to make sure that your directions are very clear when you're delegating a task initially, and then you're doing periodic assessment and evaluation of the outcome of that task. You don't want to wait till the end of shift to see if what you delegated was done. That's a big error a lot of new nurses do, because at the end of the shift, the UAP can say, I didn't get around to it, right? Yeah, you just go back, how is that? Did you get a chance? Do you need any help? Do you need any assistance? So on and so forth. Did the patient take a bath? You know what? I'm just so swamped. I'm so behind, so on. Okay, so I get at 2 o'clock, we're gonna do it together. Do you see what I'm saying? You have to kind of stay on top of it to make sure, and you have to go see whatever you delegated, was it done? If you tell the UAP, okay, you passed the front desk, right? And the specimen for your patient is still sitting there, right? Or you see a cup, or it wasn't collected, right? Those are things you need to do what? Follow up on, right? Did you take the specimen, so on and so forth? Did you get it? Okay, great. Let me run it down to the lab. Do you see what I'm saying? So those are things you want to make sure is always done, even if you delegate, right? Because at the end of the day, who's going to have to get it, do it? So you're always responsible for it. And it's really good because then they have thing like, okay, I know she's going to check, right? Or I know he's going to check, right? Or I know I could reach out for them for help if I can't get it done by a certain time, right? So those are important things that you always want to make sure that you consider as well. So of course, remember, nurses may only delegate tasks that are appropriate for the skill and education level of the individual who is receiving the assignment, right? So again, it must be within the UAP scope of practice or the LVN scope of practice. So that always relates back to the State Practice Act, right? Because that's really important, because every state has its own what? Nurse Practice Act, right? So it's very important for those of you that want to do travel nursing, before you get to that state, you need to know their practice act, because that's going to be important on what you can delegate to the UAP in that state, what you can delegate to the licensed vocational nurse in that state, licensed practical nurse in that state, CNA, whatever it is, you have to make sure. And you always make sure you know your employee's policy. You cannot delegate anything, of course, related to the nursing process. You guys all know ADPI, right? Assessment, diagnosis, planning, intervention, and evaluation, right? Anything that requires clinical judgment, right? So the biggest thing, of course, is the exception is vital signs and blood glucose levels assessment if the patients are what? Stable, right? And who always takes the first vital signs for every shift? The nurse. First vitals, oh, it's me. Admissions coming on the floor, it's me, right? Right, and that's what I'm telling you. It is who? You. Everything first is the nurse. I'm fresh, I'm first. You see what I'm saying? You have to get into that mindset. It is me. Because the biggest thing too, when you, especially when you have an admission or you get a transfer from the floor, that's part of your what? Assessment. Okay? Because that's the thing too. When I worked cardiac, we would get patients, from CCU, right? So of course I need to see them right away, because are they stable enough for me to handle with 5 other patients, right? And I've done that before, where I've had a patient coming up from CCU, and I kid you not, he was in the hallway in the little wheelchair. He was as gray as the hospital, like he like blended into the background. The cyanosis was so relevant, but who's bringing him up? A UAP. You see what I'm saying? So I said, stop right there. I immediately went to get a pulse ox. Guess what he was satting? 78. I can't keep you here. I can't keep you here. I called a rapid response in the hallway, sent him right back to CCU. No, nope, not me, not today. He's not stable. Do you see what I'm saying? So again, those are important things, because your assessment, that first, everything depends on you. No matter, like I told you, no matter what you have seen, you cannot take anything with you. Your experience, your clinical experience, so on and so forth. NCLEX is really based on a glass house model. It's a perfect medical world. NCLEX is technically based on a perfect medical world. I have all the time I need. I have all the equipment I need. I have all the help I need. Everything is, that's how you kind of look at it, okay? So those are important things. And again, only if patients are stable. So I can delegate the vital signs, after, right? If my patients are stable, I've done the first ones, they have their medication. So now they don't have to do the morning ones, but they can do the what? The 12 o'clocks, right? They can do the AccuCheck for lunch and all those other things, right? If my patients are stable. So that's one thing you have to remember. The other thing too is prior to delegation, you want to do predictability of the outcome. What is the expected outcome of the task? Okay, is it a new or routine treatment for the patient? Anything new, if you see new, who has to do it? You do, okay? Or if it's something routine, can I delegate it? Yes, right? So you always look for keywords. In addition to that, should the CNA perform first ever blood glucose check for a patient newly diagnosed with, you see all those keywords? I call them glitter. I like glitter. I like bling, right? So I like to look for keywords, right? They help me, especially when I see the words new, newly. I mean, that's fresh. Oh, who does all the fresh new stuff? I do, right? As the nurse, right? So that's really what you want to focus on. And then I look if there's any potential for harm. Is there a chance something bad can happen to a patient during that skill, right? Is there a risk for bleeding? Is there a risk for aspiration? One of the common things they like to see if you're going to delegate to a UAP or to a CNA is feeding, right? But then they'll give you a patient with myasthenia gravis. Is that a stable patient? No, they're at risk for what? Aspiration. They'll give you a patient that just had a stroke 2 days ago. Can I give that to a UAP? Right? Because they're at risk for aspiration. Do you see what I'm saying? So you have to look at the patient and their condition, right, to make sure no matter what you have seen in clinical practice, right, you're going to be the ones feeding them, right? And then, of course, is the patient stable? That's always the most important question to ask yourself when you're delegating a task. Anybody who's unstable, even if you're like, oh, I'm not really sure, they don't seem, err on the side of caution and don't what? Delegate it. If you're kind of in the middle and you're like, err on the side of caution and don't delegate it. You do it. Because that eliminates room for what? Error, right? And it keeps your patient safe. So the complexity of care, again, is this a basic or complex task, right? So again, what can LPNs do when it comes to dressing changes? They can do simple, basic, routine dressing changes, right? What if it's a central line dressing change? No, right? So that's why it's so important for you to know what it is. Yes. Huh? Mm-mm, mm-mm. That's you. Because you have to do what to the site? Yeah, really assess it, so on and so forth. So that's why it's kind of like, okay, anything that's really going to require you to do an assessment, especially when it comes to a central line, pick lines, those things, you always want to delegate it to the RN, right? Does the facility policy and States Practice Act allow the UAP to perform the task, or do they have the necessary skills? That's always a problem. And again, is judgment needed to perform the task? Does it require nursing assessment, or do I need to collect data, right? Those are things that you need to be thinking about for that particular patient, because sometimes too, if you have to do a dressing change, right, and the doctor has ordered a wound culture, right, and it's a simple dressing change, but I know there's an order for a wound culture, right? Do you think I want to do that, or do you think I want to delegate it to somebody? Mhm. You have to do it, right? Right. I want to assess it. I want to make sure that the culture is done correctly, right? Because of course, yes, or I might notice certain things and tell the doctor, hey, this is happening. Exactly. Right. So that's what I'm saying. You might have certain things. So that's why you really want to be able to think and see what's happening. Okay. Yes. Yeah, yeah. If it's basic, unchanged, patient is stable, so on and so forth, no issues, so on, so on. But that's when you look for keywords, saying patient is restless, urine is, foul, so on, this, and, when it gives you something to say, something might not be right, you don't delegate it, you do it. Do you see what I'm saying? Because it's going to require you to do what? Collect more what? Information and data, okay? So of course, does the UAP need psychosocial support or education during the performance of a task, right? There are some things that are difficult, right, for other people, right, psychologically, where they might not be able to what? Handle it, right? At the end of the day, who handles everything, good, bad, and in between? The nurse, right? So you have to always remember that. They do, but that's within their scope. Yeah. Okay. So tasks that can be delegated to the UAP, again, patients must be stable in order to delegate the task to the UAP. They can do ADLs, right? So that's bathing, grooming, oral care, hygiene, dressing, toileting, and feeding. Okay. Ambulation. But the biggest thing is they have to know, assess level of activity, and if they need for assistance. So they can ambulate patients if they're what? Stable, right? So those are things you just have to remember, right? Emptying and recording for Foley catheter output. Can they do that? Yes. Empty eyes and nose, right? Those are basic things they can do, right? Calculating and documenting eyes and nose. Are they trained to do that? Yes. Okay. Removing IV sites and Foley catheters. The biggest thing is for the state of Florida, do they do that? No, but the biggest thing is it may be facility specific and state specific. In some places they can. That's why you have to make sure you check your what? State Practice Act for that state. Florida, are they removing any IVs? And no. Are they removing Foleys? No, right? So those are things that they don't do. But can they, empty and say, okay, there were 600 cc's of urine? Yes. You see what I'm saying? So those basic things that they can do, right? Other things that can be delegated, of course, bed making, linen changes, incontinent care. Now, usually that's something too, depending on what's going on with the patient, that usually goes hand in hand with when they're bathing, so on and so forth. But if there's anything that they have to apply, like any topicals or cream, who has to do that? The nurse, right? Repositioning, right? They have to report any patient restrictions to the UAP. Can they adjust the patient in bed? Yeah, right? So they can do that. But again, if there's any restrictions or anything special, you have to make sure that you what? Communicate that with the patient, right? I mean, with the UAP. Specimen collection, report and specifies to the UAP. So again, that really depends. So if there's an order for midstream urine collection, that is ordered, who's going to be doing that? No, you are. Yeah, you want to make sure that you get those things. From the Foley catheter, can they just get a basic urine from the Foley catheter? Yes. I like to make sure that I do the midstream because sometimes, they might not know, they don't know. So you just want to make sure, but again, if it's something specific, right? Again, you do it. Yeah, oh yeah, yeah. Yes, yeah. You do it, right? Vital signs, blood sugars, weights, the assessment interventions UAP can do. So they can record those things if it's basic, predictable for a stable patient. So again, make sure you know your 5 rights, right? Right task, circumstance, person, direct communication, and always follow up with supervision and evaluation, right? That's the biggest thing. Was it done? Okay, now of course the right task identifies which tasks are appropriate to delegate to the UAP. So right task is usually repetitive, requires little supervision, and is relatively non-invasive for the client, and usually within the UAP LVN scope of practice. So you determine the right task based on the professional standards of practice, what the facility says, and of course available resources like we talked about. Now the circumstance. So what is the health status of the patient and complexity of the care of the patient's need? So vital signs for a hypotensive patient following a bolus. Would you delegate that to a UAP? No. Why? I gave a bolus, right? So I gave 500 cc's of normal saline. Now the vital signs need to be taken what? Right, but it requires reassessment. Can the UAP take those vital signs? No, I need to know if the bolus what? Worked. If it didn't work, we got a problem. I need to bolus them again. I might need to give vasopressors. You see what I'm saying? So you have to look for key words, right? I just gave a bolus to a patient that had a low blood pressure. The UA, I can't just go, oh, can you go check to make sure their vitals are good? The UAP says, oh, patient's on the floor, they're unconscious. You see what I'm saying? You need to reassess, right? That's what requires that, right? Are they going to know? No, they're not, right? So that's why it's so important, right? So you should be the one to reassess the situation. And whenever something does require reassessment, you have to be the one to do it, especially after an intervention. Okay, and then make sure you're considering their workload. Again, are they free to complete the task or are they tied up with something else? Again, that's very important, of course, in clinical practice. On boards, that's, pretty much something, of course, they have all the time in the world. You're really focusing on that one patient. But in real life and, nursing homes, sometimes they have 15 patients and they're the only UAP, right? So they have to feed, bathe, change. So you think of all of those things too, but that's in real life practice, right? And of course, right person. So make sure you verify the competence of the UAP, the tasks that must be within their scope of practice or job description or the LVN, and then of course the necessary competence and training, right? So you continue to review the performance and determine their care. So if you know that a specific UAP has a track record of never reporting abnormal patient vital signs to the RN, do you trust that UAP, right? If you know that they're not going to do something, why would you delegate it? Does it make sense? No. You know, oh yeah, I'm working with them now. All right. What do I know they're gonna do, right? What do I know they're going to do, right? And when necessary, take any steps to remediate any failure to meet standards. So in the above example, you should have a discussion with the UAP about normal vital signs range, educate on the importance of reporting these to the RN, right? And then of course, if that continues, because the biggest thing is teamwork makes the dream work, right? So if I'm counting on you to do routine vital signs, right? And you're saying, okay, um, Nurse Susie, I just took the patient's blood sugar and it's not registering, right? Because after a certain point, when they take the blood sugar, it's going to say what? It's going to say low, right? What does low mean, right? I need a what? Number. You guys know when people do AccuChecks, if it's too high, it's just going to say either high or it's going to say low, depending on the machine, right? So as a nurse, that's when you have to know, you actually have to call the lab and get a stat blood sugar. Because if you call the doctor and be like, oh, patient's blood sugar low, the doctor gonna be looking at you like, you're gonna be like, well, that's what the machine said. The doctor needs a what? Number, right? So you have to call a step blood sugar for the lab, and then of course do your interventions for the patient. But again, they have to make sure that they're telling you these things, or patient's respirations, I counted them twice and they're 24, right? Because that's gonna cause you to do what? Shift and pivot and go see what? The patient, right? Oh, they'll come find you in another patient's room and say, hey, patient in room 22, blood sugar is, 512. So that means as soon as I'm done with that patient, where do I need to go? You see what I'm saying? Yeah. So that's why it's so important. And again, that's part of the leadership portion. If you see that they're not reporting or they're not being a team player, right? You're going to escalate it to the charge RN or the what? Manager, because that's compromising care of who? Your patients, right? And it's not tattletelling, it's that there's a reason why this is happening, and it's going to cause problems because it's not being communicated the right way, right? So communicate what is collected, again, in writing, orally, or both, right? So you want to make sure everything is going smoothly for your shift. Always provide a method and timeline for reporting, including when to report concerns and assessment findings. So again, if you give specific instruction. John, can you please go help Mr. Smith in room 311 get up from the bathroom to clean his dentures? He gets up with a walker and a standby assist. Is that clear? Is that clear to you? Yeah, it's pretty clear, right? So again, clean his dentures, gets up with a walker, standby assist, so you know the room, so on, so forth, right? So that's just basic instructions for the UAP, and that's going to make it very clear for them. Do you want to assign a time frame? Yeah, breakfast is in 30 minutes, right? So it's meaning before breakfast, he needs to have what in his mouth? His clean dentures, right? So those are things that you can, if you want to expand a little more in concerning to time, right? And then you just provide expectations for follow-up communication if necessary. Yes. Mm-mm. You don't document all of that. No, if you just document AM care complete, basic things like that. If that was the case, we'd be writing novels all day, right? Yeah, so those are things you just, delegate, but you know that it's done, right? And because you pass by the room and you see him eating what? Breakfast with what in his mouth? Dentures, right? That's how I evaluate, right? To make sure he had his breakfast, right? And then, of course, there's direct and indirect communication depending on what's going on with the patient. Always make sure that you're identifying and discussing with them any performance improvements in a positive way, right? So say you're working, the PCT is having trouble getting accurate pulse ox reading on a patient. PCT keeps getting O2 sat in the 80%. This is when you should go and assess the patient, right? See what's going on, see if it's the pulse ox, so on and so forth, right? And do we have issues with the Dynamap or some of our equipment? Yes, right? And most nurses don't know. If your machines aren't working, where are you supposed to bring it? Or who are you supposed to call? If your machines aren't working, like your Dynamap blood pressure machines. Yeah, you can let them know, but it goes to biomedical engineering. They fix it. Yeah, biomedical is who fix it. Like a lot of people don't know that, but it's biomedical. That's who fixes it. Yeah, you have to call and make sure that biomedical gets it. Okay? And then you evaluate the patient's outcome status. So say you ask the UAP to assist the patient get from the bed to sit up in the chair to eat breakfast and remind him to ensure the patient's chair alarm is on. You then go into the patient's room and you see that she's up in the chair eating and the chair alarm is properly on, right? I gave directions and then I go what? I go and check, right? Is everything on? Is it done? All right, good. All right, next, right? So that's what I mean about evaluating. You give a task, so on and so forth. You always have to make sure it's what? Done. You never assume. Even if they say, yeah, I did it, you know, especially when you're new. What are most people gonna do when you're new? They're gonna test you. Are you gonna be the nurse that checks, or are you gonna be the nurse that takes my word for it? I'm gonna be the nurse that what? Checks, right? To make sure it's done. Okay, so of course, the nursing process is always related with delegation, right? So again, with the Nurse Practice Act and so on and so forth, when it comes to assessment, the RN needs to assess not only the client and the client's individual needs, but also the staff member to whom a task will be delegated, right? So your assessment will always include their strength, weaknesses, training, and experience. If you have a UAP that just graduated 2 weeks ago, as opposed to a UAP that's been doing this for 20 years, do you see what I mean about experience, right? Because they're going to know a lot more than the one that graduated what? 2 weeks ago, right? That just started, right? So again, that's something you always want to make sure that you're familiar with, right? So assessment is that initial phase of the nursing process, right? So it involves the interpretation of the significance of objective and subjective information, right? In order to formulate what's going on with the patient. You always complete the initial assessment upon admission whenever the patient's returning from OR, any type of surgery, or upon a change in condition. If anything changes in that patient, who's assessing them? You are. Always. Okay? LPNs and UAPs might collect some data for the RN to interpret and evaluate. However, the responsibility of the interpretation evaluation of the data, which requires nursing judgment, is always done by the RN. Okay, so only RNs can make a nursing diagnosis, right? So the biggest thing is you use your critical thinking and critical decision making in the activities and what you're going to accomplish. Implementation, the most common nursing actions that are delegated fall under implementation of the nursing process. So of course, for example, the nurse can delegate measuring urine intake and output to UAP, but the decision of how frequently the eyes and nose need to be measured, which requires nursing judgment, must be made by the RN. The nurse may delegate administration of insulin to a diabetic client to an LPN LVN, and also delegate the monitoring of the blood sugar after the insulin to an LPN LVN. However, the RN retains the accountability for using nursing judgment to hold the regularly scheduled insulin for a client, right? So when would I make the decision to not give insulin? Hypoglycemia, right? So that's what I mean about critical nursing information, right? And again, what type of insulin am I going to give? Which dose of insulin? How long the insulin should be held, right? So again, you're always the one responsible for that. And implementation always includes education to the patient and the family, right? So an LVN can only teach from a standardized care plan, right? So again, assisting in client education or reinforced teaching that has already been what? Completed. So that's the only time they can educate, meaning I already did it, right? They're just reinforcing what was already told by the RN. Is that clear? Right. So that's the only time when it means like they can educate, right? And then of course you always evaluate, like I said, all the delegated tasks, and of course making sure that they're done correctly. So of course, aside from assignments, other tasks that can be delegated by RNs to other RNs, right? So say a busy nurse might ask another nurse to perform a task for him or her, right? Or a nurse might be assigned to another unit with a different client mix. While it's easy to assume that the delegator always applies the principles, you always make sure you're using the 5 rights of delegation, right? Because the biggest thing is you might assume that a nurse possesses more advanced training than there actually is, right? So for an example, when accepting the delegated responsibility, it's prudent to remember the following principle. Am I the right person? So remember, as an RN, you always accept a responsibility for the task, right? So again, I look at different things within their scope of practice and their competence, right? Again, would I give a nurse a patient on a ventilator if they've never even had a patient on a ventilator before, right? Are they ACLS certified, right? So can they do advanced cardiac life support? If not, should they be in the ICU? No, right? So those are important things you have to know. Do they have certain types of training, titration of medication? This sounds common, but again, this is something to we consider when people are floating and so on and so forth that we'll talk about, okay? And always remember, biggest thing is we always keep this in mind when we're delegating tasks, when we're doing prioritization. Safety comes what? Period. Period, period, period. Keeping that patient safe is my number one priority. Alive and safe, right? That's always my priority, right? So of course, delegation tips to remember, no one else operates under your what? Nursing license. That license is a specific number with just to you with your name on it, right? And again, when delegating, you do not transfer the authority and accountability that goes with what? Your license. Very important to always remember, right? Your license is not jeopardized by the actions of others to whom you delegate, as long as, again, you're sticking to the 5 rights. They're competent to perform the task. It's within their scope of practice. You use sound judgment in massing the needs, conditions, so on and so forth. Because at the end of the day, if you delegate something to a UAP that other people might say, I know looking at the shift, they can't handle that. Whose license is it going to fall under? Yours, right? So again, that's why it's so important to always remember. Look how hard you guys are working just to get that what? License. You want to use it just because you delegated something to the wrong person? No, right? So of course, remember how to utilize the chain of command and know how it works. Again, UAPs report patient issues to who? The RN, right? Not the who? Doctors, right? Keep this in mind, right? RNs report to who? The doctors, right? So again, if the patient is unstable and likely needs MD to intervene, you need to focus on taking over the care of that patient. That includes the tasks that the UAP would normally do. Is that clear? Right? So if there's a change in condition, so on and so forth, and yeah, I know I have stuff to do, but you know what? They need to eat, they need to do this. I have to take over that task because it requires for me to do what? Assess them, see how they're doing, how they're tolerating their activity, so on and so forth, right? So those are important things to remember. Right? So those are just my tips. All right? You're welcome.